Good evening, everybody. Thanks for joining our webinar tonight. We are just waiting a few seconds so that everybody can join, and we will shortly start. Thank you. So here we are. Maybe we can start.
Yeah. So good evening to everybody. Thank you for being with us again with another successful webinar from the ESSM. First of all, I'd like to thank, as always, our sponsor, IBSA, for supporting our educational activity with an unrestricted grant. So I'd like to remind you that the webinar will be recorded and, as always, will be available on our website in about 1 month time. All the previous webinars are already available in our society website just for members. So I'd like also to thank the President-elect, Michael Ford, who is working very hard along with our scientific chair, Paolo Capogrosso, for the organization of our next Congress that will be in Vienna from the 20th to 22nd of February next year. I'd like also to remind you our educational activity, the ESSM School, which will be held in Budapest, as always, in the mid of November, from the 15th to the 24th of November. So please go to our website and in order to join us, in order to register. I'd like also to remind you that we have the possibility also to join the two educational activity. So the EFUS, the project that we launched the last year in order to improve your skills and your viability and your possibility to use female ultrasound for the detection and the evaluation of a female sexual dysfunction. Again, it will be in Budapest. I'd like also to remind you the possibility to join us. Several members of the ESSM will be there on the 5th International Consultation on Sexual Medicine that will be held in June from the 28th to 29th in Madrid. There will be the possibility to discuss with the most important experts worldwide on several topics related to the sexual medicine. Surgical Academy, our another fantastic ESSM project. In this phase, we are running the first step of the project, so the online webinars. The first one have been already done. The next one will be on next June. So the first, since last year, we open all the first step of the project to all people, so not just the members. So please join us. And if you want to go in depth of this educational activity, join the ESSM as a member. Please go ahead. Obviously, I hope that at least in Vienna, our update publication of our manual will be available. I know that the educational committee, along with Kobe, Mikala, and several other people are working very hard to finalize this project. Next. Now I'd like to introduce the chair of our educational activity, Professor Daniar Osmonov, who worked along with the committee very hard in order to provide you the best evidence and the best webinar for this year. Please, Daniar.
Thank you, Giovanni. Thank you very much for joining us. We have more than 100 registration. I hope that will be helpful for you also as a preparation to the Budapest school, and I hope you will join us during our examination to obtain fellow European Board of Sexual Medicine. Today we are having another pleasure to have two fabulous speakers. We will talk not about only men's health, but also about couple health. So, and we have my co-chairman, known scientist from Turkey, Dr. Selcen Bahadir, and we will talk about aging male and aging female. Our first speaker is Christian Fuglesang, Jensen, and he received his medical degree from the University in Copenhagen in 2015, and currently enrolled as PhD at the University of Copenhagen. He is a well-recognized expert in the field of male fertility at the Copenhagen University, and he used to work in University of Michigan and Herlev and Gentofte Hospital, performing research in various and different areas of andrology, basically in male infertility. Our second speaker is well-known Professor Linda Vignozzi. She's endocrinologist from the University of Florence. At the University of Florence, she receives her medical doctor and PhD in the field of endocrinology and metabolic disease. As you know, Linda Vignozzi is a chairperson in various societies worldwide. And I'm happy that you, despite of the very late hours, are with us and listening to our webinars. I would like to remind you that you should ask the question using Q&A section, not the chat, please. And we will discuss each talk after both talks in the end of the webinar. Our next webinars will be after summer pause, and we will have two additional webinars supported by IBSA, state-of-the-art webinar in regenerative medicine, as well as myths and reality of the cosmetic genital surgery. After a couple of weeks, this webinar will be also available as a pre-recorded or recorded session on our homepage. So,
thank you so much for the introduction. So we can start with the first presentation.
Yes.
Good afternoon to everybody. So it is a great pleasure for me to be here, to have been invited by European Society for Sexual Medicine. So thank you very much. My duty is to give you the latest update on the female sexual health. So this is my disclosures. What I decided to do is first to give you an update on the latest news in the pathophysiology, so to fully understand why we are trying to develop a new drugs and therapy for FSD. So now we know that androgens has a very important role in women's sexual health, and indeed by using systematic review and meta-analysis we're able to demonstrate that endogenous androgens are linked to female sexuality. And indeed, we found that total testosterone level was lower in women affected by female sexual dysfunction, and this was true even when we subanalyze premenopause as compared to postmenopausal women. And even this in the younger women, when we exclude hormonal contraceptive, this association was still present, and so no major difference were observed when stratifying for natural menopause versus surgical or mixed menopause. And when we compare the presence of HRT versus the absence of HRT, and also when we compare different age at the menopause. The highest association observed among all the sexual dysfunction domain and desire domain, but this association reveal a significant propagation bias. And this is also true when considering free testosterone level, which was lower in women with a sexual dysfunction. And again, desire domain was the one that was mainly associated to free testosterone level. So we perfectly know that there is a role of androgens in women, and in particular that low testosterone level is present in women with desire domain alteration that we call HSDD. And again, when we found that testosterone therapy was able to have an important clinical effect on women with sexual dysfunction, this was also observed in surgical menopause and in natural menopause. But when we consider these clinical studies, this is a very important systematic review and meta-analysis of randomized controlled trial. This leads to the global consensus position statement that was published by all the very important society dedicated to sexual medicine, but also to women health, such as our European Society for Sexual Medicine, but also the International Society for Sexual Medicine, the International Society for the Study of Women's Sexual Health, and also the Endocrine Society, and so on. So what about this global consensus position statement? What was recommended was that in naturally and surgical postmenopausal women with HSDD, with or without concurrent estrogen therapy, testosterone replacement therapy, so testosterone therapy was able to improve, to have a beneficial effect in sexual function, including increasing versus placebo or comparator the average of 1 satisfying sexual events per month. This was also associated to an improvement of subdomains of sexual desire, arousal, and orgasmic function. And this was also revealed by very important preclinical studies showing that this effect was exerted mainly by testosterone via its androgen receptor. So it was a main androgenic activity in the brain, and this was not associated to any aromatizing activity of testosterone into estradiol. So this is true that low testosterone is related to HSDD in women, but it's also true that testosterone therapy for HSDD has an important role, a beneficial effect, and this was probably mainly related and mediated by the activation of androgen receptor in the brain. So another important news is that the role of androgen has been not only discovered in the brain modulating HSDD and sexual desire, but also in the peripheral organs that are very importantly activated during women's sexuality. So androgens has been also demonstrated to have an important beneficial effect in the treatment, for example, of genital urinary syndrome of menopause. And indeed, the International Society for the Study of Women's Sexual Health produced an expert consensus panel review just stating that vaginal dihydroepiandrosterone, but also vaginal testosterone were important potential treatment for this condition. And we have to mention that prasterone was approved by FDA, but also by EMA in the management of moderate to severe dyspareunia due to menopause. So we have something in our hands that should be used for the treatment of GSM. And this is a very important news because we know that androgens exert an important beneficial effect in the vagina, and the vagina is a very important androgen target tissue, since we observe that human vagina is also able to produce androgens that is important for its function and its activity. And indeed, by starting from the HEA, human vaginal cells are able to produce testosterone and DHT, which is the main active androgens in the body, but this testosterone is not converted into estradiol. So again, a mainly androgenic effect that was not related to the estrogenic one, even in this tissue. And which is the role of androgen receptor and their activation in the vagina. So what we were able to demonstrate in our lab was that the human vagina is a target for androgens, since androgens are able to maintain the relaxant and contractile capacity of smooth muscle cells in the vagina, but also to modulate inflammation, and so to counteract the induction of a chronic perpetuating inflammatory disease in the vagina. And indeed, what we also demonstrate by using again the preclinical study was that testosterone was able to modulate all the machinery related to nitric oxide, cyclic GMP, PD5, PKG, relaxant pathways. So testosterone was able to potentiate nitric oxide pathways, the relaxant pathway mediated by cyclic GMP, in order to induce a relaxant activity in the, not only in the clitoris, but also in the vagina. And indeed, when we treat, in this observational prospective pilot study, 81 women attending our clinic for sexual symptom, we treat with systemic testosterone, and then we measure clitoral hemodynamic parameters by using the dynamic color Doppler ultrasound of the clitoris. And what we found was that systemic transdermal testosterone was able to increase the peak systolic velocity of a clitoral artery after 6 months of treatment as compared to the baseline. And this effect was not observed by using estrogen treatment. So again, here we were able to demonstrate that testosterone was also important for clitoris and vagina. So these were also a very important target tissue for androgens. And again, looking at the global consensus position statement, what was very disappointing was that we perfectly know who needs the treatment. So we know that the treatment is needed in naturally and surgical postmenopausal women with HSDD or with without estrogen therapy, but we have not any testosterone available to treat these women. So the global position statement also state how we should treat these women. So starting with a 3 to 6 months trial, and then to move on to see any clinical effect. And we also state that we have not to measure testosterone at the baseline to make a diagnosis of a reduction of testosterone in women, because the immunoassay that we use normally routinely are not so accurate for this. And then also because we do not have any cutoff level to make this diagnosis of hypoandrogenism in women. So we have to try a trial and to try to treat women with HSDD with testosterone, see the clinical effect. But we do not have any testosterone therapy in several parts of the world. In the past, we have a testosterone therapy approved by EMA, so the European Medical Agency, but not by FDA. And so this is a very disappointing. We need something absolutely to try to figure out and to treat our women and to exert all this beneficial effect that we, both the preclinical and clinical studies are revealing for testosterone in our patients. So again, here is true everything I show you, but in several parts of the world, including Europe, we do not have any compound, any drug for this treatment. So treating women with FSD with testosterone is still challenging. And actually in Italy we have a compound testosterone propionate, which is testosterone ester, and with a relatively short acting life, and so it's considered something like the natural or bioidentical form of testosterone. This is in the market for men, but also for women, for example, frigidity with one injection every 2 days, then to be repeated after the 3 months. But the major problem here is that this compound is able to induce a very important and high increase of testosterone level in the blood. So we need to make a very important reduction of the dose. It is difficult to be performed in this formulation. And so we have to look at the past, a very important clinical study that we have in the past about the efficacy and safety of a new drug to be used on demand. And this drug was actually based on a very important beneficial effect that we did know for testosterone in women. And testosterone was associated in one compound with sildenafil and in one compound with buspirone. So in this trial, 200 women with a female sexual interest and arousal disorder as declined by the DSM-5 were randomized in different regimens in this 3 double-blind randomized placebo-controlled trial. And so there was a placebo group, then there was the testosterone group, then there was a sildenafil group and buspirone group, and then all the combinations therapy. And what was observed here was that previous study, based on previous study that have shown that women with low sensitivity did not respond to testosterone plus buspirone, and on the other hand, that women with a high inhibitory pathways did not respond to testosterone plus sildenafil. So this previous study revealed that they should, in this new randomized double-blind randomized placebo-controlled trial, they have to stratify according to low sensitivity and high inhibitory pathway in these women. So this stratification was made. And what was observed was that testosterone and testosterone plus sildenafil was able to induce a very significant effect in satisfying sexual events as compared to baseline. When this was performed, was used in women with a low excitatory pathway. And on the other hand, the combination between testosterone and buspirone was mainly effective when it was administered in women with a high inhibitory pathway. So this means that we should stratify in some way, but it was also something very important because it was an effort to produce a new drug to be used in women with FST. So we are starting a new era, most probably, we hope so, because we have 2 drugs that are being developed. The first one is Librido. That is a combination of sublingual testosterone plus phosphodiesterase type 5 inhibitor sildenafil that I presented you before, that needs to be used on demand to increase sensitivity to external and internal sexual cues and to the physiological genital sexual response. And on the other hand, we have Libridos with a combination of testosterone plus buspirone to increase the brain response to sexual cues, and is seems to be able to reduce inhibitory response to these sexual cues. So this medication are not currently available, but some study, and we are trying to promote the development of these 2 drugs immediately in the next future. Indeed, we are moving towards a precision medicine in women with a female sexual dysfunction. This is what we are facing right now, and this is very new. The way that we would like to differentiate and to make a very tailored approach for our women, not considering all HSDD women it's the same. And indeed, when we look at the HSDD, we need to recognize that there is an HSDD mainly related to the increase of inhibitory pathways and one mostly related to the reduction of excitatory pathways. And indeed, while in our university, we try to understand which is the relation between inhibition and excitation in the sexual brain by using a tool for prediction of the diagnosis and treatment of hyperactive sexual desire disorder in women. We use the sexual inhibition scale and sex excitation scale questionnaire to try to predict a diagnosis of HSDD. And what we found was that a value of the sexual excitation scale below 46.5 was able to discriminate for HSDD or for women with HSDD, and on the other hand, also a sexual inhibition scale value of above 32.5 was able to predict HSDD women with HSDD. And the sex inhibition scale was mainly increased, the value was increased in women with dyspareunia, so with sexual pain, but also with partners with actual medical condition, but also with a personal history of viral hepatitis. These were the mainly amnestic findings that were associated with the increase of inhibitory scale. On the other hand, this was also associated to the reduced number of times sexual partners, but also with a mean age at first sexual intercourse above 20 years old, but also a sexuality that was better, equal, or even better in masturbatory pathways than with the coital sex. And what about the sexual excitatory scale? This was in contrast mainly related to different organic factors. For example, the increase of systolic blood pressure or diastolic blood pressure, but also, for example, with the past use of recreational drugs or current use of recreational drugs, or but also to the lack of privacy during sexual activity, or having a partner with premature ejaculation, but also with the length and duration of sexual relationship. And what we found was that the sexual excitatory pathway was positively related to the level of testosterone in these women, while it was not associated with this hormone was not associated with the sexual inhibitory scale value. So when we look at in 55 patients with a diagnosis of HSDD that we treat with the transdermal testosterone therapy, and we look at the follow-up during the 6-month treatment, we're able to demonstrate that the lower the sexual excitatory scale domain at baseline, that we found the higher the improvement of FS5 desired domain at follow-up after testosterone treatment. So we do confirm that the sexual excitatory pattern was mainly related to testosterone level here. So looking at the summary of this very important news, we also were able to demonstrate that we should actually move towards a more tailored approach for the future. So most probably the next year, during the new updates of this webinar like that, we could truly put more evidence on this new approach, very respectfully, for differentiating different women with the same sexual problem, but most probably with very different background. So a very special thanks to my colleagues that help me day by day and suggest me everything I need to do for try to disentangle these very important topics for the future of sexual medicine, and not only in Italy, but also in Europe and the world. And as a president of the International Society for the Study of Women's Sexual Health, I invite you to join us, to join our society, to know even more about women's sexual health, but also to join us in the next Congress in 2025. That will be a joint Congress between ISWISH and ESSM in Atlanta, US. Thank you very much.
Thank you so much. We will now start with the second presentation. In just a few seconds that we can upload the video. Thank you so much.
Good evening, everyone. I would like to thank the ESSM and our sponsor, IBSA, for the opportunity to participate in this ESSM webinar. The topic of today is sexuality and aging of the couple, and I will give some updates on men's sexual health. During this talk, I will briefly describe the potential decline in sexual function of the aging male before giving you some latest updates with a focus on regenerative therapies that partly aims to restore the function of tissue that might be damaged by the age processes, making these treatments specifically interesting for tonight's webinar. I will also highlight a few other updates regarding the treatment of erectile dysfunction that will be the condition of focus for my talk this evening. So we will start out by looking at the effects of aging on sexual health. With aging follows an impairment of sexual function, and this can be visualized as a modification of the sexual response cycle in men as seen here. The red line represents the normal response, while the blue line represents the male aging response. Thus, aging men might experience problems with low libido, erectile dysfunction, and orgasmic and ejaculatory dysfunctions. This potentially modified sexual response cycle is reflected in a decrease in sexual activity that is observed with increasing age. Around 90% of men aged 40 to 60 declared that they were sexually active within the past year, while this number fell to 40 to 50% in men in their 70s and 80s. Obviously, the sexual activity is also affected by other factors, including the general health of both the man and his partner. The specific sexual conditions affecting the aging male include late-onset hypogonadism, erectile dysfunction, Peyronie's disease, and orgasmic and ejaculatory dysfunctions. As I said, we will be focusing on erectile dysfunction and on the regenerative therapies that might counteract the tissue damage taking place with increasing age. So moving on to the regenerative therapies, these include the regenerative injectables, platelet-rich plasma, and stem cells, as well as shockwave therapy. Regenerative therapies aim to replace or restore tissue that has been damaged by either age, disease, trauma, or other factors. A common theme for these treatments is that they, rather than providing merely a care for the patient, they can potentially provide a cure. This is often what patients are seeking. They prefer cure over treatment. As said, the regenerative therapies include stem cells that can be derived from bone marrow, adipose tissue, umbilical cord, or dental pulp. PRP is created using the patient's own blood, and of course we also have shockwave therapy. Common for all is that they harbor potential angiogenic and regenerative properties. Injection with stem cells work in both a direct and an indirect fashion. Thus, stem cells can differentiate into endothelial and smooth muscle cells and can indirectly serve as a regeneration treatment of the endothelial, blood vessels, and nerves. Platelet-rich plasma works indirectly with regeneration of nerves and increase in nitric oxide synthase but basic studies in vasculogenic ED is lacking. Further, most of the knowledge on mechanisms of action of regenerative injectables are derived from animal studies that hardly translates into a clinical setting. Now, before discussing these regenerative injectables for ED, I do want to highlight a few other important updates in erectile dysfunction that are both relevant in the aging male, namely the potential of using echocardiography to better risk stratify patients with ED in regards to development of cardiovascular disease, and the use of oral dispersibles to treat erectile dysfunction. Now, erectile dysfunction is defined as the persistent inability to achieve or maintain an erection sufficient to permit satisfactory sexual performance. Now, importantly, satisfaction is a part of the definition. Roughly, the prevalence of ED is 40% in men aged 40 years. With increasing age, the prevalence of ED also increases to around 70% of men aged 70 and over. Now, interestingly, the proportion of men having concerns of ED falls with increasing age, as seen on the graph to the right. Further, among older sexually active men, almost 50% have reduced rigidity with erections. This might indicate that with advancing age, normal erections are not an absolute prerequisite, and older men can have satisfactory sexual activity with suboptimal rigidity with erections. Now, several factors are important to maintain a good erectile function. This is a snapshot from a review published in 2020 looking at determinants of erectile dysfunction. As you can see, the odds ratio for ED is increased among smokers and cannabis users, while physical activity has some protective effects on erectile function. Similarly, arterial hypertension, diabetes, obesity, elevated triglycerides, and metabolic syndrome increases the risk of ED, and these factors are also important as a risk factor for developing cardiovascular disease, which brings me to the next topic, namely erectile dysfunction and the risk of developing cardiovascular disease. Now, we know that with erectile dysfunction, men with erectile dysfunction have about 50% increased risk of developing cardiovascular disease and coronary heart disease, and 35% increased risk of stroke. Now, with the aim of gaining a better understanding of the cardiac characteristics in men with erectile dysfunction, Dorokan and our team enrolled 100 men with erectile dysfunction and subjected them to echocardiography. When looking at the results from the echocardiography, it was interesting to see that 83% of all the men had reduced global longitudinal strain, which is a marker of systolic dysfunction. Further, 4 patients had manifest heart disease when they were evaluated with echocardiography. Now, it is the hope that echocardiography can help with risk stratification of men with ED to find early signs of cardiovascular disease that might then be prevented. Now we move on to treatment of erectile dysfunction. And as all of you know, PDE5 inhibitors are highly effective and stands as a reference for other treatment modalities. And here you can see increases in IIEF scores based on the type of PDE5 inhibitor and the dose used. The black horizontal line marks the minimal clinically important difference, and all PDE5 inhibitors exceeds this change. Therefore, PDE5 inhibitors are a cornerstone in the treatment of organic ED, reflected in the EAU guidelines. Nevertheless, the discontinuation rate of PDE5 inhibitors is around 50%. This might be due to failure of treatment, and if that happens, there are a number of things that you need to address before abandoning treatment with PDE5 inhibitors. First, it is recommended to try the particular drug at least 6 times, as every sexual activity is different. You also need to check that the medication has been taken correctly with adequate sexual stimulation, dose, and time from administration of the drug to attempts of sexual activity. You also need to be aware that absorption of both sildenafil and vardenafil can be delayed by a heavy fatty meal. And lastly, you can try switching to a different PDE5 inhibitor. But now you also have the option of prescribing sildenafil as an oral dispersible. Oral dispersibles are drugs created as thin, flexible sheets that dissolve rapidly when placed in the mouth. This allows for an easier and quicker drug absorption, but with the compared bioavailability as tablets. The sildenafil oral dispersibles comes in an intermediate dose of 75 milligrams. One small observational study investigated the effect of sildenafil oral dispersibles. 31 men with ED were followed for 8 weeks, and the oral dispersible films were found to be both safe and effective. And you can see the spaghettiogram with increases of IIEF scores over time for each participant to the right. Meanwhile, these data are obviously limited, as this is a small, uncontrolled observational study. Nevertheless, it might be practical in some men to suggest oral dispersibles, which are now available. Now, the final topic, and the topic for the next 10 minutes, is the regenerative injectables that are being used for treatment of erectile dysfunction, namely stem cells and platelet-rich plasma. But before looking at the evidence of treatment of ED with these injectables, I would like to give you some perspective and highlight the quite dramatic placebo effects in treatment of ED. Now, this study is a randomized trial where all groups got placebo treatment. Group 1 believed that they were treated, Group 2 were unsure, and Group 3 believed that they got placebo. And overall, 35% improved their IIEF-EF category. But even in the group that knew they got placebo, the IIEF-EF score increased from 10 to 14, which is clinically significant. So please keep this in mind. Now, treatment of ED with stem cells holds certain promises. They promise to give better erections with lasting effects and minimal side effects. And now let's take a look at the clinical trial data. Here you see 9 studies investigating the use of stem cells for erectile dysfunction. First, I would like to draw your attention to the small number of participants in each study, ranging from 4 to 38. Further, please notice the follow-up times of 6 to 12 months. As stem cells is a treatment that promises lasting effect and a cure, 12 months seems rather limited, and we must remember that there are good alternatives, namely PDE5 inhibitors. Now, when looking at the erectile function change, the data are quite heterogeneous, with results such as 2 reaching ability to penetrate, no IIEF change, 8 men who recovered EF, IF increase of 5, mean IIEF increase of 2, median IIEF increase of 4.5, and so on and so forth. The heterogeneity is also the case for the patient populations and whether or not concurrent use with PDE5 inhibitors was allowed. So all in all, it is quite difficult to make a conclusion on the effectiveness of stem cell injections based on these data. Then let's take a look at platelet-rich plasma. Treatment with platelet-rich plasma holds the same promises of better erections, lasting effects, and minimal side effects. And again, let's look at the clinical trial data. Now, this is an open-label clinical trial on 31 men with ED and metabolic syndrome who were treated with platelet-rich plasma 3 times with an interval of 15 days and then followed for 6 months. At all time points after PHP treatment, the IIEF score had increased from 18 to 20. Now, bear in mind that this is actually a smaller increase than expected from placebo, and the minimum clinically important difference was not met. This study is by Shahir and colleagues that was recently published, and this is a larger placebo-controlled study of 100 men with mild to moderate ED. They were randomly assigned to two different groups, one receiving 3 injections of PRP and the other saline injections with a 15-day interval and a follow-up for 6 months. As seen here, the mean IIEF score increased from 18 to 22 in the treatment group, and this was okay. Meanwhile, it was quite surprising that there was no placebo effect in the saline group, as also seen in this table. Further, no statistical comparisons between groups regarding the overall IIEF score was made, and there was no pre-registration of the study protocol. Now, this is another study by Puglios and colleagues published in 2021. They included 60 men with mild to moderate ED, and they treated them with either PRP or placebo, 2 injections, with 1 month interval and a follow-up for 6 months. As you can see, there was an increase from baseline to 6 months in IIEF score of 3, but there was also lacking effect of placebo in the placebo group. Further, when looking at the patients reaching the minimum clinically important difference, this was clearly better in the PRP group compared to the placebo group, so this was quite promising. But regarding the limitations, this was a single-center clinical trial with strict eligibility criteria. We had a small number of patients, a short follow-up period. There were 5 dropouts, and the study was underpowered to perform any comparisons in patients with different degrees of ED. And finally, it cannot be extrapolated to other PRP separation systems, and this is a general limitation for the studies of PRP as different methods are used. Now, the last published study that I will mention is the study published by Masterson and colleagues in 2023. They included 61 men with mild to moderate ED and performed a randomized clinical trial comparing 2 injections of PRP versus placebo and followed the patients for 6 months. The primary outcome was % of patients at 1 month reaching the minimal clinically important difference, and this was 1 month after the second injection. And when looking at this primary outcome, there was no difference between the treated group and the placebo group. And this is also visualized in the IIEF scores that were quite similar throughout the study. Also, they looked at penile Doppler parameters and found no difference. They had 1 minor event in each group, a plaque formation in the PRP group and a hematoma in the placebo group. And again, obviously, this is a quite small randomized study. Now, before reaching my conclusions on regenerative injectables, I do want to highlight 2 abstracts that were presented at the EAU and AUA very recently. The first is a study called the PREPET study, which is a randomized clinical trial including men with moderate to severe ED who were PD-5 non-responders. And they were given 6 weekly injections with PRP versus platelet-poor plasma and followed for 28 weeks. They presented an interim analysis at EAU on 27 men and found a much lower response rate than expected in the treatment group, and also the development of tunical plaques in 3 men in the treatment group. And this has led to an investigation about the possible early termination of the trial. The second study was presented at the AUA a very short time ago, and this was a randomized clinical trial on 57 men with mild to moderate ED who looked at the combination of platelet-rich plasma plus shockwave therapy versus placebo with saline injections and sham shockwave therapy. And the men were treated with 2 injections and 5 rounds of shockwave therapy treatment. And In the study, there were no adverse events, but when looking at the trial outcomes, there were no difference between the two groups in IAF scores or in the number of patients who reached the minimal clinically important difference. So in conclusion, in the era of evidence-based medicine, there is not enough evidence to justify regenerative injectables in clinical use for erectile dysfunction. So the take-home messages from this webinar is that there are male aging effects on sexual health. There is a potential of echocardiography to risk stratify patients with ED in regards to cardiovascular disease. We must remember that we have effective ED treatments, but oral dispersibles is a new method for administration of PDE5 inhibitors. And finally, there is no evidence for the efficacy of regenerative treatment for erectile dysfunction. So lastly, again, thank you to the ESSM and our sponsor IBSA for the opportunity of presenting here tonight. Thank you.
Thank you very much.
Good evening, everyone.
Great talks and a lot of information, sometimes controversial, but I have several questions, and I would like to ask Linda about the studies. So all the studies are in a long-term regime. So PDE5 inhibitors or PDE5 inhibitors plus testosterone, sildenafil plus testosterone. Do you see an efficacy of on-demand use of PDE5? If you look to the data presented by your colleague Christian, the oral disposable films is a brilliant idea for the male as a rescue option. Do you think that it could be equally work in female?
Thank you, Daniar, for this very interesting question. So I had no time to enter into details, but what we demonstrated was that all the machinery that is related to nitric oxide second GMP pathways in the male genital tract, and in particular in the penile tissue, was exactly the same also in the female one. So I would expect that what we are observing in the male space that is almost 20, 30 years behind and very far away from the research in the female space would be something that we should look at to address the future research in the field of male sexual health. So I would imagine that it could work also in the female space, because in the genital tract there is a lot of PDE5 as well in the male one, and is also very responsive to the regulation by the hormonal sex hormones, and especially is regulated by testosterone as well. So we have not to forget that testosterone and all the androgens are very represented in the female blood. So these hormones are actually reducing by a factor of age. So most probably we should think about a combined effect of the two, testosterone and PDE5, to fully cover all the aspects that should be adjusted or fixed in a special population, such as women in postmenopause or aging women. So it makes sense. We have to work on that, but I would trust that maybe they do work as well.
Thank you.
Also, we have some question from our audience. Christian, I think this is for you. Are you there, Christian?
I'm here. Yeah.
Okay. Regarding aging male sexual intercourse issues, how can we balance between patients' needs and cardiovascular disease events?
Well, obviously, this is something to consider in the aging population. But I mean, practically, it's not always a problem, because there are several ways that you can be intimate with your partner, and you obviously need to inform about that. But if you are very worried in a patient with heart failure, for instance, you could get an evaluation by your colleagues from the cardiology department, and definitely it's not something that should rule out sexual intimacy with your partner.
Okay. We have also some question also to Christian again. I would like to ask for PRP. Until when should we continue this injection? Is there a consensus for third treatment regimen? What's your clinical approach?
Yeah, I saw that question coming just before reaching my conclusions, and I do think that my conclusions rather answers both of these questions. So obviously there is no consensus for the treatment regimen with PRP, because it's still experimental, and there's still a lot to learn with PRP yet. My clinical approach, well, we don't have one because we don't use it in clinical practice. We use it in trials, and we are right now, Professor Mikkel Fod and I, designing a trial investigating this further, because I do believe that these regenerative injectables belong in clinical trials as of now.
Thank you. Linda, I have a question concerning the treatment of hyperactive sexual desire disorder. Based on the data on PRP on male, do you think it could be useful to use PRP to inject clitoris, for example, or to combine PRP plus shockwave in female, plus maybe testosterone PDE5 inhibitors? As you already mentioned, we are 30 years back or 20 years back in comparison to the male treatment options. Do you think it could be comparable to the male hype of using PRP on these regenerative methods of treatment?
So this is an interesting question, and the only concern that I have, and you mentioned clitoris, so I have no data just to say if this device could work or not, but I mean, we have to think that it's not only a matter of the clitoris. So we have a very expanded and wide vascular tissue over there. So it's not only clitoris, but there are a lot of vessels that surround the distal vagina. So all this vascular compartment needs to be taken into account. So maybe it's more challenging in women because you do not have such a big organ outside to treat. You have all hidden inside. So you have a small clitoris, and then you have a lot of vessels that surround the vagina. And this means that you have to take care of all these vascular diseases as well. So it is more complex for anatomical reason, but I mean, we could study on that and see if there is a potential application also in women as well.
Can I make a question, Daniel?
Yeah.
So to both of you, Linda, can you also emphasize, Linda, because you have a lot of data, and obviously due to time reasons you did not present a lot of them, regarding the role of ultrasound for the evaluation of female sexual dysfunction. And Christians, you can also compare maybe the role of ultrasound for the evaluation of male sexual function, Linda.
Yeah. So this district, just to support the view that there is not much difference between the two genders in this respect, as we know that in male, the genital district, the penile district is a very good mirror of what is happening in the cardiovascular system in our patients. So erectile dysfunction in some way could predict major cardiovascular event, We are also studying the same in the female space, just using the same methods by using the echo-color Doppler ultrasounds of the clitoris and measuring the pulsatility index, which is an index that mirrors the vascular resistance in this very, very small artery. So you have to think that the clitoral artery is roughly around 0.7, 0.9 micrometer of diameter. So it's lower than the benign one. And indeed, we found that all these parameters, so the vascular resistance there was increased in patients with metabolic syndrome, but also with cardiovascular events. So this means that we were also able to find a cutoff level of this Doppler ultrasound parameter just to try to figure out how we can use to predict the cardiovascular event. So we are very far from with very strong evidence because our very small studies in only one center, our center, so we have to replicate and duplicate. So in this view, we have to thank the President Giovanni and all the ESSM to give us the way to spread the knowledge of Doppler ultrasound, organizing the EFUS, which is the Female Ultrasound School of the ESSM, in order to make and to practice more research in this field and to amplify the research in this field in order to collect all the data and try to make this gender equity that we should face in some way according to the cardiovascular risk and the relationship with sexual dysfunction.
Christian, do you think that the male ultrasound...
May I ask a question?
Yeah, for sure.
Christian.
Yeah, please. Christian, do you think that male ultrasound...
I have some problems with my...
Yeah, go ahead, Daniel.
Yeah, I'm sorry. Christian, you know that, and this is actually truth, it is not a secret that treatment with PRP or maybe attempts to treat the patients with PRP, it's more or less a gold mine for a lot of private urologists to earn the money, and to be honest with you, and with all of us. But this is a different story in the clinical setting. And I'm really disappointed and cooled down after the latest publications, also placebo-controlled trials, and after latest data, even as abstracts during AUA. But what do you think the future of PRP? Is it really something which has substance, or it's just something which will disappear in the years? What do you think? Your personal opinion?
Well, I think that we need to look at it in two ways, because you said that obviously some of it is money driven. So for a business model, there might be a future. And to be honest, regarding the evidence, I'm not sure. Right now, it's not looking that optimistic. As you said, the most recent results were not very promising. We saw the Pipette study and the cocktail trial, who both showed negative results or not better than placebo. So I'm not sure that it will evidence-based has a role in the future, but I guess we'll see.
Yeah, thank you. So this is very interesting, and this is always hot topic. And I think it's important to talk not only about men's cells. We are talking years about men's cells, but we do not talking about female cells. And actually, we should talk about couple health, and maybe to use already known methods of treatment in the male erectile dysfunction, also in female or combined. And I think it's very interesting studies on use of PDE5 inhibitors and testosterone HSDD. Well, Linda, I'm wondering whether there is another studies which are ongoing with a different PDE5 inhibitors, because you demonstrate only sildenafil with testosterone, but we know that the efficacy might be different if you use, for example, avanafil or tadalafil. What do you think about this?
Yes, it makes sense that all the PDE5 inhibitor would work in the system, and there are some studies that already tested the effect of these compounds in very special population. For example, women affected by diabetes mellitus. So it was something that has been already studied. So this compound, there's more studies in very special population, I know, but we have to work and go further on this way, because I would imagine that we could find some very important treatment for our patients, because you have to think that for GSM, for example, we only provide therapy, local therapy with sex hormones or hormonal replacement therapy, very locally administered, but we should also think about a very special population of patients where these sex hormones are not allowed to be given. For example, patient with breast cancer that has a very important atrophy in the vagina, several symptoms there. So we should imagine more and more therapy for and try to study more therapies and new device, new drug for targeting different molecular mechanisms that are there. And we should not be afraid that some drugs are being developed for the male space, because as I told you before, it makes sense, and there are evidence right now that they would work also in the female space. But we have to study more and more deeply.
Thank you very much. Giovanni, what do you want to summarize our webinar?
Yeah, thank you, Daniel. First of all, I'd like to thank again all the people involved, all the speakers, Linda. I know you are very busy. I'd like to thank Linda as a friend, but also as the president of ISWISH. So having ISWISH here is a pleasure for the SSM. So I'd like to thank Christian, who is the sub-chair of the male committee of our scientific committee. So thank you, Christian, because I know that you are doing a great job along with Paolo Capogrosso and all the people involved in the scientific committee. Obviously, Selcen, you are always a friend of us, always with us. Thank you for being here. Thank you for all the people involved. Many people from worldwide. We see from India, Vietnam, Canada, South America, and so on. And again, Daniar, thanks a lot. As you said, I think we covered all aspects of sexual function from male to female, and especially for women and for the couple. And I think a very important key message coming from this webinar is that we have several therapeutical options, especially for male, but there are very new options for male, such as oral dispersible film. Also, we have some new promising drug coming from women. But also, the issue is that we need to pay attention to the couple needs, since we do not, for sure, having a rigid erection or push the couple to have a rigid erection, because sexuality can be further than just an erection. So I think this is the final key message that we can driven from this webinar. Thanks again, and have a good night. Bye-bye.